Welcome to this review of the medication management of urinary tract infections. I am Dr. Amber Cann. Let's get started. In general, we can classify UTIs as upper and lower. The upper UTI is known as pyelonephritis. Lower UTIs are known as cystitis. We use the cutoff there of anything that happens downstream from the kidney is generally a lower UTI or cystitis. Anything in the upper portion of the kidney output and anything that involves the kidney is the upper UTI or pyelonephritis. You may also hear a lower UTI referred to as a uncomplicated UTI or uncomplicated cystitis. It just involves the UTI. It's usually seen in premenopausal, non-pregnant women with no known urological abnormalities or comorbidities. A complicated UTI is also the term that we use for acute pyelonephritis. It's a bacterial infection that has the complication of going into the ascending urinary tract. So it spreads from the bladder to the kidneys and their collecting systems. Urethritis is an inflammation of the tube that carries urine from the bladder to the outside of the body. And prostatitis is a swelling and inflammation of the prostate gland. UTIs are simply the most common bacterial infection. They're most commonly the reason why females of childbearing age are exposed to antibiotics. Upwards of 60% of women will develop a UTI during their lifetime, and 25% of those will have a recurrence within 12 months. Our treatment goals when treating a UTI are, first of all, eradicate the causative organism. We also want to prevent and treat any systemic sequelae that may result from the UTI. And then, of course, we want to prevent a recurrence. Whenever we're selecting a medication, we should take into account both patient-specific factors and drug-specific factors. When selecting a treatment for a UTI, we typically don't know the causative organism, but we can make educated guesses based on history from the patient or knowledge of the types of bacteria that you see in your region. Things that we have to consider about the patient are past antimicrobial agent exposure, the ability for the patient to afford a medication, and the convenience of the dosing regimen. The drugs that we use to treat UTI differ in several different ways. For instance, beta-lactams and fluoroquinolones have high concentrations in the urine, so we can give very short courses of therapy at lower doses and achieve good results. Sometimes a minimum GFR is required to enter the urine. So as a patient's GFR decreases, the amount of the drug that enters the urine decreases and therefore makes it less effective. And then sometimes if we're treating a renal abscess, then we might need blood levels to be at a certain level, and certain drugs reach blood levels quicker and for longer periods than other drugs. I want to address a clinical controversy over preventing UTIs. It has long been conventional wisdom that patients may consume cranberry juice as a preventative measure. And most people think that it is the action of the acidification in the urine that prevents growth of bacteria. However, that has not proved factual in research. It appears the fructose and the tannins in the cranberry juice interfere in some way with the pathogen's growth. We know that because other treatments that lower the pH of the urine, like ascorbic acid, don't seem to be a reliable preventative measure against UTI. So if a patient asks you about using cranberry juice to prevent UTIs, it seems to be helpful. It's not the reason that we thought it was, and it's definitely not the sugary, artificially sweetened cranberry juices that are very commonly available. Another method that patients may ask you about in preventing UTIs is probiotic supplements. Lactobacillus probiotics do seem to help prevent UTIs. What they do is they decrease vaginal pH, and that reduces the likelihood that E. coli and some of the other usual organisms can colonize. Probiotics can be found in supplements and in fermented foods such as plain Greek yogurt, cheese, and kefir. So this does happen to be a good recommendation for patients, especially for preventing recurrence and just general prevention. For a long time, conventional wisdom has said that to treat a UTI properly, you should give an antibiotic and also a urinary analgesic like Nasal Powerdine. The Nasal Powerdine is said to treat the uncomfortable burning sensation that can happen with a UTI. Now, products like this don't have any antimicrobial activity, and they can discolor body fluids, so patients could be alarmed by having a bright red urine after taking a couple of days of these medications. They are available over the counter in products like Azo, Urostat, and Pyridium. So patients may reach for this type of product when they first get symptoms of a UTI, thinking that they're treating the UTI, when actually they are only treating the pain associated with it. Some recent research has shown that there are very serious but rare side effects to Nasal Powerdine. It's not an entirely innocuous medication. So it's important to understand the risks if you do recommend this product for a patient. If you're going to use it, the max dose is 200 milligrams of Nasal Powerdine 3 times a day for only 1 or 2 days of the treatment. After that, the antibiotics should start to kick in, and they won't be experiencing the burning or pain upon urination. Here's a quick list of the most common medications used to treat UTIs. SMX-TMP is an abbreviation for sulfamethoxazole trimethoprim. It's commonly known as Bactrim or Septra. It does reach very high urinary tract concentrations, and therefore we can use it for a very short period of time with great results. It does have some adverse effects that the patient should be aware of. Rash is common, but more serious side effects like photosensitivity and Stevens-Johnson syndrome are possible. Nitrofurantoin, or Macrobid and Macrodantin, is another very common and effective way to treat UTIs. In fact, not only for treatment can nitrofurantoin be used, but it can also be used at lower doses for prophylaxis against recurrence. Fosfomycin is a newer product on the market for UTI treatment. Its brand name is Monurol, and it stands out because it is a single dose therapy. It has low levels of resistance, and it's a very convenient one-day dose for the patient. Fluoroquinolones like ciprofloxacin and levofloxacin were commonly used to treat UTIs in the past. They had some serious side effects, the least of which was photosensitivity, GI upset, dizziness, but they've always had a black box warning related to tendon rupture and tendinitis risk. And now newer research has indicated that they may be causative or at least associated with spontaneous aortic aneurysm. For these reasons, I don't recommend using a fluoroquinolone unless it is the only option. Augmentin is amoxicillin clavulanate. It is increasingly a preferred item for an uncomplicated UTI because the usual causative agent, E. coli, is getting resistant to other medications that we've been using. So amoxicillin clavulanate is a preferred agent for treating UTIs. Cephalosporins like cefaclor and cefpodoxime are used for UTI. They don't offer a clear advantage over the other items that I've mentioned, but they are an option if the patient has a preference. That single dose therapy of fosfomycin is a unique dosage form. It comes in a box that has a foil sachet inside. The patient just tears open the sachet, pours the contents into water, and drinks the dose. You don't have to worry about the patient not finishing their full course of therapy because it is a single dose therapy, and there seems to be low resistance of causative organisms of UTI at this time. Treating an uncomplicated UTI only requires about 3 to 5 days of therapy. I've listed the usual drugs and their typical durations in that first column. In patients who are pregnant, we may want to treat for a slightly longer period of time. We can use all of the medications on this list. I do put an asterisk by nitrofurantoin. It is a preferred agent in patients who are pregnant with a UTI, but you do not want to use nitrofurantoin up in the weeks leading up to delivery. So I would just generally recommend avoiding nitrofurantoin in the third trimester. For complicated cases of UTI or pyelonephritis, we do need to treat for longer periods of time, and we might need to admit the patient for IV therapy if they are very ill. We take a stepwise approach to managing a UTI. The first thing we do is categorize it as a complicated or uncomplicated UTI. Then we determine the susceptibility, the causative pathogen, or at least the usual causative pathogens in our region. We assess the patient for characteristics that may affect our drug choice. Then we select from our first-line agents and give that to the medication to the patient for the suggested period of time. And then, of course, we assess the symptoms and change therapy if needed. There are some cases where patients are symptomatic but don't have the threshold of bacteria that we typically see in a UTI. It's sometimes known as urethral syndrome. It's characterized by the symptoms of UTI, dysuria, and maybe pus in the urine or pyuria. But it doesn't show in lab results the normal level of bacteria in the urine. It's mostly caused by a small number of coliform bacteria. So what we do to treat this is we just give them a short course of therapy, usually with Bactrim, SMX, TMP. And then if the bacteria is still present, then you would need to grow and culture it and test sensitivity. It should be noted that if the patient's sexually active, there are other things that could be causing this other than bacteria normally that cause a UTI. The patient should be assessed for chlamydia, and you can treat that with a single dose of azithromycin or 7 days of doxycycline. The flip side of that coin is asymptomatic bacteriuria. That is where a patient has bacteria in the urine at the threshold or above that we usually see in a UTI, but they are complaining of no symptoms. It's more common in elderly patients and in pregnant women. The Infectious Disease Society has published 2019 guidelines for ASB, and I've provided you the link there on the screen. The newest recommendations state that pregnant women should be screened and treated for ASB, and treatment should be about 4 to 7 days with the choice of antimicrobial agent appropriate for that patient. But they also do not recommend screening elderly patients or residents of long-term care facilities. Now let's talk about the complicated UTI or acute pyelonephritis. A typical patient will present with a high-grade fever, severe flank pain, and some severely ill patients will be very dehydrated and maybe having some nausea and vomiting. Very sick patients should be hospitalized and treated with IV antibiotics. And if they're not quite that sick or they don't have other extenuating circumstances, you may be able to get away with a IM treatment of an antibiotic in the office and then sending the patient home with some oral medication follow-up. The goals of treatment, of course, are the same. Achieve therapeutic concentrations of an antibiotic agent in the blood and the urine and eradicate the infection. Typically, we do see first-line therapy as fluoroquinolones in this case, ciprofloxacin or levofloxacin for 7 to 14 days. That's in the PO realm. If the patient is not acutely ill or severely ill, we can also use Bactrim for a longer period of time, so 14 days. We can also use Augmentin or cephalosporin, and we typically do that after a single dose of ceftriaxone given IV or IM. For really sick patients, I definitely recommend giving at least a single dose of ceftriaxone in the emergency department or in the office and then sending them home on PO therapy. But of course, if the patient is very ill or elderly or has other comorbidities, then a hospital stay is warranted. Here are some examples of how you could follow up parenteral therapy so the patient can continue treatment in their home environment. You'll notice most of the durations of therapy are at least 10 days here. Well, unfortunately, up to 80% of UTIs are reinfections. That means that prevention of a recurrent UTI and prophylaxis is a key strategy in managing it. We consider it a recurrent UTI if the patient has more than 3 infections in a year, and that's when the patient is a candidate for long-term prophylaxis. If it's less than 3 infections per year, we treat it as just individual cases, a short course of therapy at the symptom onset. UTIs in men are considered more complicated to treat than in women. Uncomplicated UTIs or just cystitis is rare in men, and so most are considered complicated just because of related structural abnormalities that are causing the UTI. As men get older, the most common UTI cause is bladder outlet obstruction, and this is commonly caused by prostatitis or benign prostatic hypertrophy. We manage UTIs differently, and they tend to be a little more difficult to eradicate than when we treat female patients. Some of the things that can complicate UTIs in men are listed here. Homosexual activity or anal sex with female partners can put men more at risk for complicated UTIs. Any kind of instrumentation or obstruction like catheters or kidney stones can cause UTI in men, and then men who are uncircumcised just tend to be more at risk for UTIs in general. One of the main ways that treating men with UTIs is different than treating women is that men just require prolonged treatment. We typically will start with a longer course of SMX-TMP or a fluoroquinolone for 10 to 14 days. Okay, let's talk about some patient cases. We have here Nora. She's a 32-year-old sexually active female who presents with a low-grade fever, pain, and frequency on urination. And she takes oral birth control for contraception. She's regularly seen by a cardiologist for a congenital heart arrhythmia. So the first question is, what is the most likely causative organism of a UTI in a female young patient? And knowing that, how do you proceed with therapy? If you have access to it, I highly recommend that you obtain a copy of the Sanford Guide. It is the absolute authority on treating patients with antimicrobial therapy. The usual causative organism for most UTIs is E. coli. If you had a Sanford Guide, you'd be able to look up E. coli as a cause of UTI, and then it would suggest several different options for medication management. I think in this case, the most reasonable way to approach it is to prescribe augmentin, that's amoxicillin clavulanate, and give the patient about a 3 to 5 day course of therapy. Next up, we have Ben. He is a 67-year-old male who lives in an assisted living community. He takes medications for cholesterol, blood pressure, and BPH. A routine urinalysis revealed that he had bacteria in his urine, and it was confirmed with 2 consecutive cultures, but he complained of no symptoms. The first question is, do we treat him? And the second, if you decide to treat him, how do you proceed with that therapy? It appears that our patient Ben has a case of asymptomatic bacteriuria. And the ASB guidelines have been published that say if a patient is found with asymptomatic bacteriuria, we do treat it just like they would if they had symptoms. In this case, his condition may be complicated by the many medications that he takes, by BPH, which could be causing a urine obstruction, and by the fact that he lives in an assisted living community that typically would be closer quarters than he might be living in if he were at home alone. The recommendations are that we do treat him, and we can provide him with a prescription for SMX-TMP And if you recall, men need to typically be treated longer than women, so he may need a course of 10 to 14 days. Our third patient is Eve. She's 78 years old. She lives with her son's family. She takes a diuretic for blood pressure. She presents to the ED with a high fever, low back pain, altered mental status, and they determine in the ED that she has a complicated UTI or pyelonephritis. So the question is, do we treat the patient inpatient or outpatient? And once you have decided that, how do you want to proceed with her therapy? Complicated UTIs can be treated on an outpatient basis. A lot of that depends on whether the patient can manage therapy alone and if they're only moderately ill. In the case of our Eve, she is a 78-year-old woman. She lives with her family, and so she may have some difficulty taking care of herself. And just because she has a high-grade fever and that altered mental status is troubling to me. I think in her case, we would definitely admit her for some IV antibiotic therapy. I don't think fluoroquinolones are the best option for this patient. She's elderly, and as patients get more aged, they tend to have more risk of cardiac arrhythmias. We know the fluoroquinolones are ones that put patients at risk for cardiac abnormalities, so I would avoid the fluoroquinolones in general with her. Probably a IV cephalosporin for several days is indicated for Eve. Thank you for joining me for this review of the medication management of urinary tract infections. I am Dr. Amber Cann.